Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from this beautiful, almost spring morning here on the first day of March. We're delighted to be here. I'm here, of course, with the ever-faithful Doc Hawk. Questions continue to swirl around vaccine equity as well as they should. Today, we're going to spend time talking with folks from here at the hospital and the Mid-America Regional Council on efforts to make sure that people who are technically challenged or lack access to technology can get signed up to get a shot. Everyone deserves an equal chance at COVID vaccination. But first, Doc Hawk, Medical Director of Infection Prevention and Control. How are you, and how are the numbers?
I'm good. Worked on the weekend, so I was here all weekend. It was all right.
Yeah? The
numbers here, though, are really good as far as acute inpatients for COVID-19. 16 patients.
Yes.
Acute. So 5 of those in the ICU with 2 on the ventilator. 32 still in that recovery period, but under 50 now. 48 total patients, including the acute.
It has been, God, was it July or August since we were at that level?
It's been some time.
Man, doesn't that feel good? And you know why the numbers are so low, Hawk?
Behavior.
I think a lot of it is behavior, and I think we know that because we haven't seen influenza and RSV.
Yeah.
It's one thing we can attribute this or that, but the corollary is no influenza, no RSV, or nearly none of either.
Yeah.
That there's a reason for that, and that reason has to be good behavior by you, meaning all of our audience out there and everybody in the Kansas City region. We have got to continue that behavior because it's winning the day. We're going to get a little challenged as the weather gets nicer and people want to get back out and get together again. I think the polar vortex probably helped us. That's a silver lining of the vortex, I guess. But, our numbers just, they're so much better than they were.
Yeah, I think we're doing good. We're good for hospital capacity, PPE, employees who are not sick or quarantined, hopefully because of the vaccination. And then hopefully now, not only behaviors, but we can start to roll out more vaccine to more and more of the general population.
Oh, man, we got to hope that that's true.
Yep. And then Hayes has 14 with 8 acute active and 6 in that recovery period. So their numbers are pretty good, too.
Also down. They've still got a few, though. That's still, relatively speaking, in the population for Ellis County, that's an important number and not to be ignored. So for all of us, we still have to take COVID-19 seriously. It's still out there. And I think we're still concerned about the next possible surge that could occur in April and May as people get back out, they get together again. The bars and restaurants are clearly opening more, and we see people coming together in different venues. I know there are concerts starting to be planned. You can begin feeling people want to come back to more normal, not normal, back to a closer resemblance of normal. Hopefully we will continue to mask and exercise those things which have brought us to this degree of improvement. Let's see if there are reporter questions out there this morning.
Good morning, Cody Holyoke, KMBC 9.
Hey, Cody.
Little joke to start the month of March. My friend says this is the first time since record keeping began that the month of March has actually lasted more than a year into another March.
That's pretty good, Cody. I like that.
It's like Groundhog Day all over again. Yeah, that's all right. I stole it, so it's good. As we get into March and it being almost a year since they declared a pandemic, I was curious your thoughts on that, especially as we now have a third weapon in the fight against the virus.
Yeah, you bet. Well, Cody, I'll say that I think that all of us are a little bit of a weary soldier. It has been a long journey, not one any of us anticipated lasting this long. Although as you look back at it, you have to ask ourselves, why wouldn't we have thought it was going to last this long, given that the coronavirus can mutate and do the things it does? I know we're coming up on our anniversary program here in a few weeks. I think you're going to probably see pictures of how smart we were at the very beginning when we were all huddled around one phone in a mass group or lined up with reporters here in the studio room. All the things we would, when we see that, we're going to cringe. It has been a year unlike any other, Hawkeye. I think words escape me of how to do it. I think Michelle, who is our interpreter this morning, last week probably put it all in perspective about her parents who passed away from COVID-19, the profound impact that has had. And while we sometimes try to keep the show a little lighter, because that's kind of who we are, and we try to be honest and thoughtful, but also have a little bit of fun while we talk about this. I think the reality is that this has been the year of unmeasurable sorrow as we try to understand what we have experienced together and what we still face yet to come. Hawk?
Yeah, I think that's exactly right. I think we have been lucky because we've been able to come to work. And there have been a lot of people who have been unable to go to work. That has caused a lot of problems. Our children are affected because of it. They haven't been able to go to school. We know that the average life expectancy in the United States has decreased by a year now because of this pandemic. There's good information out there. And that doesn't even start to touch on all the social issues that have gone on in combination with the COVID pandemic as well. So, I think it has just been, a lot of looking back, 2 weeks, because we always say in 2 weeks we'll know more. I think a lot of it has been looking back 2 weeks or a month previous, because I think we all have tried to keep moving forward just one day at a time. And as you get to that, just get through the next day, trying to do things to increase your knowledge to get to that next day. And then when you look back on it, as we look back today, what was it like the last time we had 48 total patients in the hospital? How long ago was that, July or August? So I think the main thing is everybody has been affected. There may be some silver linings to this pandemic, but it has been a one step at a time and a one day at a time process.
Cody, I don't know. Can I ask you a question, Cody?
Sure.
You've covered this for a year. How has it impacted you?
I just think being tuned in every day has helped with just my personal knowledge of this. And so when we get all kinds of viewer questions, I think it is nice to kind of set them straight, because as you know, there's been so much mis and disinformation in the last year. It's cleared up a little bit now, but I mean, and you see the numbers reflect that. But, just really staying on top of it, because there's a lot, and you guys are we're very thankful for you, because you're able to sort through all of the information in the medical journals that, lay people like us go through. But, there's been so much. I mean, we're still working a week from home. We're still rotating. But as Dr. Hawk said, some people haven't been able to go back to work yet. So it's just, it's crazy to think that it's been a year.
It
almost.
has. And it doesn't feel so different to think what normal is like, because I think this has sort of become so normal. And I think the tragedy and the sorrow is that it did not have to be this hard, nor really this long, because you see places around the globe where they have taken this much more seriously and with much greater community sharing around the risk and the success. And they've experienced success in ways that we have not been able to do. And I think had we just had a very open, honest conversation without the hyperbole and without the disinformation from the very beginning, we could have done what we're doing now. Because what we're doing now is really, it's a result, sure, of some people being out there and having been infected. It's a result of getting people vaccinated. But the very low rate of influenza and RSV tells a compelling story, as do other countries around the globe, that when you take this seriously, you can win. And it's just taken us a long time to get to win. And it should not have taken us that long. And I think the one thing that Hawk and I have tried to do is not flapjack. We're not going to flap our arms and jack with the truth. COVID weariness is as bad and as long and as hard as it is. We don't need to try and add to that by adding a layer of disinformation and misinformation that adds to the sorrow and the death, because that is what it does do.
And I think that, with our faith, we can continue to have hope and optimism that we are daily one step closer to some sort of normalcy as it was in 2019.
Faith, hope, and science. Mm-hmm. They can move mountains together. Other questions?
Hi, guys. It's Taylor at Channel 41. How are you this morning?
Hey, Taylor. How are you?
Good, thank you.
Good.
Question about as we get ready to send more older students back to school this month. We've got several districts that are getting ready to send some of their secondary school or secondary districts back to in-person learning, which is an entirely different thing than elementary schools, because elementary school students are as I have 3 at my house, are more likely to go to school and come straight home, and that's about all they can do. Older students are going to be driving around, going to different athletic things, different social events. For parents who've had older students at home for the last 5 or 6 months, can you give us an update right now on best and worst practices for young people as they re-enter?
You bet. I think it's the same rules we know. The rules of infection control travel with you wherever you go. Wear a mask, keep your distance, don't go out if you're sick, cough into your elbow, wash your hands. Do those things, and we can reopen schools and high schools successfully, just as colleges have been able to reopen successfully. And I think if we do that, we'll see exactly the effect we've already had. I keep coming back to this point. I think it's so salient. I'd love to hear your comment, Hawk. The low rate of influenza is astonishing,
Yeah.
right? And we all got our flu shot. We got our flu shots every year. It is not this good. RSV, same thing. Common colds. How many people get the cold right now? And the reason is simple. Infection control works, not just for COVID-19, but for all of these viruses. So as people go back out and they want to be around their friends and they want to do the things they want to do, just try to follow the rules of infection control. And I know it's hard. I know it is hard because it's not our norm, but it is what's safe.
Yeah, and I think on the institutional level or the school district or the building level, you know, the main things that we know that are going to protect students and their families, but also the adults, the certified people in the schools, is those things that you've talked about. De-densification, making sure you can mask and keep the distance as much as possible in those places. Those things are going to be what is going to be important for not leading to increases in cases. And then, of course, once we are able to get most of those teachers, administrators, counselors vaccinated, that will help as well. But we know that the students may be living with people of vulnerable populations, so they can bring it home as well. So I think continuing to do those things about de-densification, masking, distancing, and then, you know, outside of school, I think is where we do see the majority of spread of the disease. It is when, just as Taylor had mentioned, getting out into those social groups, whether it's teams or practices or getting together, meeting outside of school somewhere, whether it's at people's houses or restaurants, things of that nature. That is where the spread comes. And I think we just need to, every household needs to continue to try and instill that, you know, in their young people about, you know, if you have to meet outside, try to stay distant, try to do those masking. It's very hard to talk with young people about those things because we know that a lot of those things, even for adults, that doesn't work. But I think that is where we will see a lot of, and I think that has been going on anyways. It's basically just the fact that they haven't been going into the brick and mortar schools, but we know that they have been getting together outside. We know that sports and other extracurricular activities are going on as well.
And do you think that as the things got colder and people went inside and they didn't get out quite as much, do you think that's had a difference on some of our transmission rates?
I do. I think that especially the polar vortex cold, you know, not just our winter cold, but what we had, you know, 2 weeks ago, and for the last, you know, 10 days before it really started to get a little bit warmer, I think that has had an effect. And I think most people were bundled up in-house in their own bubbles. You know, of course, there were still some other things going on, but I think the movement was greatly reduced.
Yeah, I think so too. You know, on a hopeful note, though, yesterday was an important day because it was the first day of spring training baseball. And so I was trying to do a little work while listening to Royals radio and enjoying the heck out of that yesterday because, you know, there's just something a little hopeful about getting to go back to Kauffman Stadium. I think I'm seeing 8,000 fans per game or so, and I'm gonna, you know, I think I feel comfortable enough now, having watched these results of what happened with the Chiefs and other organizations, and what we've been able to do with on the Lawrence campus. I think I'm gonna go to a baseball game, man. I'm ready to go.
Outdoors, yeah,
Let's do that. All right. Other questions?
I had one quick follow-up too. I
Please.
apologize.
No, you're good.
You know, with J&J coming out today, and they're being sent overnight, and that new vaccine is a possibility. Do we know about how long? Because we talked about how long when you get the vaccines right now with Moderna and Pfizer, you should consider yourself to be not immune, but covered, for lack of a better word. Is it different with a one-shot vaccine than compared to two? Whenever you're just getting one and no booster?
No, I mean typically, and I think there was another separation curve in the J&J FDA brief where it shows people who got vaccinated and who got the placebo, and really I think it's still about at that 12 to 14 day mark when you see those numbers of cases in the people who only got the placebo start to increase and the number of people who got the vaccine stay at a very low level. So I think it's about that 12 to 14 day, and that's what it is for most vaccines. That's what we say for influenza vaccine as well, as, really waiting for that 14 days to consider yourself, fully protected. So I don't think there's much change with that. I'll go back and look, but it's really at that 12 to 14 day mark.
Hawkeye, I'm getting this sense as I look through try to wade through some of the J&J data and compare it with what we're seeing in Pfizer and Moderna, and looking at the Israeli study as well, that essentially these vaccines behave much more similarly than they do differently. Now, granted, a little bit of a different mechanism, but in terms of their epidemiology, I suspect that if you looked at Pfizer and Moderna, you'd find remarkably similar data with one shot, and if you did J&J, which they are now planning to do with two shots, it'd look a lot like Pfizer and Moderna. I'm going to bet that they're going to end up much more similar than they are different. What do you think? Yeah,
I think so, and that's what we have to really point out. There is really 85% efficacy at 28 days after, and high 70s after 14 days. But the very important part for this, and this is the part that we are so concerned about, 100% efficacy in preventing death for J&J. And so they are very similar. The mechanism of action, you're still producing the spike protein, you are mounting an immune response, T cells and B cells, to that spike protein. So when you actually see it in the true infection, you have protection. But the big part of efficacy is really against the severe and critical disease and keeping people out of the hospital, and most importantly, death.
Yeah, that's a really big deal. And I think that at the end of the day, the best vaccine you get is the one that's in your arm. And I think we'll be having that conversation tomorrow with Dr. Ault, who I hope will be able to join us, as well as Lee Norman, how to choose between vaccines. And I think the answer is the one you're offered.
Yeah.
Other questions?
All right, last one, quick one from Cody about this J&J vaccine. Do you guys get a forecast of like the percentage of shots are going to be Pfizer, Moderna, J&J, or does it just come from the state and you get what you get?
Yeah, it's more the latter. And actually, the way it works right now for us, Cody, is that at present, the state gets their vaccine allotment from the federal government. I am assuming that we will get 2% of whatever amount of J&J is getting shipped. I don't really know that for sure. I'm not sure the state knows that for sure. And then the state is giving it to the health departments. We're not getting direct shipments of vaccines, so then we get whatever Johnson County gives us. So I think there will be some discussion with us and Jay and just to say, Advent and Olathe and KU are the three health systems that are involved in vaccinating people in Johnson County, along with the county. The county's been predominantly focused on those who are over 80, and I think they're going to start going to and essential workers and teachers, et cetera. I think they're going to lower that to over 65 as well this week. But it'll be, what the county decides we're going to get is what we get. I think as vaccine numbers ramp up in terms of production and distribution, that there will be a multi-phased approach throughout Kansas that will involve health systems, offices, as well as public health departments, pharmacies, and other groups to try and get people vaccinated. One of the really good news is about the J&J vaccine is I think it could be distributed to physicians' offices. If you look at it, its dynamics, it doesn't have to be kept at it's cold. It's more stable at room temperature. Hawk, I think that's something that could work in a physician's office, and we might even be able to do that, as I know that would be another effective means. Because when you ask people, who do you trust most about vaccine information, they say their primary care physician.
Yeah, absolutely. And I think once, nobody was clamoring for the influenza vaccine, and it wasn't the big demand. But once we have more supply, there will be a continued evolution, and it most likely will not be just the state giving it to the health departments, but it will be that other multi-pronged approach, private health systems, private pharmacies, as we've already seen, news stories about that, and then of course health departments as well. So, and that is all going to be a good thing moving forward.
All right, let's turn to our guests. Jana Jackson is a call center manager here at the health system. Jana, welcome. She and her team have been spending hours calling our patients who have barriers to registering for the vaccine. This is a really important story because one of the things we found when we started using our normal technology, because we would push it out in MyChart, which is part of Epic. And MyChart is a way that you can interact with your hospital chart and get information and get messages. Or we emailed folks. there are a lot of people who don't have access to MyChart and don't have email on a regular, consistent basis. And if you send something out, say, hey, you got 24 hours to sign up for a vaccine, and you don't get that message, then, your 24 hours and that window's gone. So he said, this is not good enough. We're going to have to use snail mail, and we're going to have to use phone calls. And so Janet Jackson and her team have been doing that, and we're going to hear from her in a moment about that work, about calling people and see how that's going, because we want everybody to have their equal chance at that vaccine. But then we also have Dr. James Stowe, who is the Director of Aging and Adult Services, and lead for the Managed Services Network at the Mid-America Regional Council. We're going to say that you're with MARC because it's so much easier to say, otherwise I'll stumble all the time. We've been partnering with MARC throughout this. Dr. Stowe, let's start with you, first telling us about the service you provide and how COVID-19 has added to the focus. How are you helping vulnerable populations? How do you make sure vaccine distribution is equitable? How do you make people think that they're all going to feel like it's safe and that they are going to be treated fairly? That's just a few things you need to do. And you're charged personally with it, by the way. So there you go. Good luck.
Thank you for that. I appreciate it. We every day we help older people remain in the community for as long as possible out of nursing homes and in their homes where they want to be through services that support them. And during the pandemic, our focus has transferred to helping people remain isolated in a way that's supportive of them, helping to keep them safe with increased home delivered meals, transportation to critical appointments and those type of services. And we started to become aware that a portion of the individuals that we serve had limited access to some of the registries that were used across the region to enroll in the vaccine. And so, the work that we do in the community is through frontline community-based organizations, largely a nonprofit network of providers. And those organizations are truly embedded at the neighborhood level in the diverse communities across the metro, in the urban core, in minority communities, really with staff, volunteers, and administration that understands those communities and can relate to them directly. So that's a huge asset, and we're now employing that asset to kind of help with this vaccine registry campaign that needs to happen for our folks who are over 60.
Yeah, that's a lot of work to be done in order to get that. Janet, your team spends a lot of time making those outbound calls to those who are 65 and older. How's that going?
It's going resoundingly well. I think it's been refreshing for our team to be able to do what I feel that we've always done best. If you can't come to us, we come to you. Those calls are resoundingly met with gratitude from our 65 and greater population. As we all know, a lot of these patients have had limited access to even their own loved ones. So to have a team call them as opposed to them having to try to gain access themselves has gone very well. We had last week, one of our triumphs was an 87-year-old gentleman who had gained such confidence through our guidance through self-scheduling that he joked about getting a Twitter account. And so we're having those successes every day. We've even ramped up efforts on the weekends to place those outbound calls.
Yeah, that's a big deal. So how much time does it spend when you are on the phone with someone to kind of get them registered, et cetera? How much manpower does that take?
The time can vary. There, of course, is a small percentage of those who are not interested in being vaccinated. Obviously, those calls are a lot quicker. If a decision is made to be vaccinated, we have two options. We can guide the patient through activating MyChart, accessing MyChart, becoming familiar with the process, and then guiding them through self-scheduling. Those calls on an average are about 20 minutes, but it's not uncommon for those to exceed 30 minutes, just depending on the technical competency of the patient. And for those who are just not interested in integrating MyChart, our team is very capable of scheduling the patient. So they're given the option. We've been very surprised that more than half of those that do want to be scheduled really do want to learn how to leverage MyChart. So in addition to being able to be scheduled for vaccination, they're now also able to leverage MyChart for their general health care. So it's a win-win.
That is a big win. And Dr. Stowe, tell me a little bit, are you guys seeing the same thing with people that once you reach out, they want to get more literate, electronically literate? Or talk to us a little bit about what's the response you're seeing, as well as, do you share Jana's experience that most people say, yeah, I want the vaccine?
Yeah, our response is really open to the public to call us. So for those older adults who do have some type of digital barrier to using the vaccine registries that are online only, that's really what our service is about. So we're primarily seeing those who are really interested in pursuing the vaccine, on their own initiative, pick up the phone and give us a call. And the vast majority of people out there are confident and capable with the internet, but there's a population that simply don't have digital tools in their household. They don't have internet in their household. And you even run across those older adults who have tried it on their own, and for one reason or another have just not been able to complete the registration process. I helped a couple, both of them were 75. They lived in rural Platte. They did have internet. They were able to navigate online to the registry through the state Missouri Vaccine Navigator system, click through the survey items, but simply weren't able to complete the form. There was some glitch that they ran into. And I was able to help them get registered and move through that process. And they just need a little bit of assistance. And so we respond to where people are at, what they want to do, and we just help them complete that task.
Yeah, good work there. So Jana, when you're doing this, are you reaching into diverse communities, or is it really older? How do you decide who to reach to right now?
So right now, we are reaching out to our 65 and greater population. Essentially, we are provided with a randomized list based off of the dosage that we received. As we all know, as you shared, we are limited to what we're being provided through the health departments right now. So there's a randomized list that is generated, and we're able to quickly kind of pair that up against our EMR and determine who has an email address on file, who is MyChart active. And so while we would certainly use MyChart, email, even some mailings to communicate with those who have the capability to receive that information, that list will also contain those that are not able to receive information that way. And that's how we obtain our list as to who we should reach out to. So it is a diverse population. The only requirement to be on that list is that you are a patient of the health system and that you are 65 or greater. And we just start from the top anytime we get a list, and we don't stop until the last person has at least been contacted to offer scheduling.
That's awesome. How many phone calls have you all made, do you think?
We've made about 2,100 to date.
Okay.
We make over 100 a day. And again, we are extended our service hours to the weekend as well. So,
how many folks are making calls on any given day? How many people do you have doing it?
On any given call, we have up to 10 making phone calls.
That's awesome. And so it probably takes a while to get somebody. Once you get them on the phone, you got to get them registered and do all those things. That's a lot of dedication. So thank you guys for the great work that you're doing. By the way, for those of you who are listening and may want to know what our phone number is, and I think, Jenna, correct me, but this is the number a patient can call if they want to get help making a vaccine appointment. Is that right? 588-913-588-1227. 1227. There you go. Is that up on the screen? I hope that's up on the screen. 913-588-1227. I feel like I'm now at an auction, or I'm part of the NPR fundraiser as I'm trying to go through those phone numbers. All right. Hey, let's turn to questions from the community. Bob's here with us today. Jill's out. Jill apparently wanted to try breaking her wrist to see how that felt, and hopefully she's getting better, but we're going to talk to Bob today.
I'm told it doesn't feel too good.
That's what I understood that.
And we are getting a ton of questions about the J&J vaccine, and I think Since tomorrow one of our guests is going to be our own Dr. Kevin Ault, who is
Yeah.
on the CDC Advisory Committee, we're probably going to save those for tomorrow.
Yeah, if there's a couple that look pressing, we're
Yeah, if
happy
they're
to
really
try and
pressing,
answer
but
some.
they're all kind of asking the same,
but we're
some
gonna
of the
be
basics. So
we're going to be hitting that with both Dr. Norman and Kevin Ault, who is an OBGYN infectious disease doc here, who's on the CDC Advisory
Yeah.
Committee that consults with
Big time.
CDC about the use of the J&J vaccine. So I know we'll all have a lot of questions, but we'll take a few today just in case somebody can't.
well, we do have one that's actually on today's topic.
All right.
Trish says, I have family who are homebound, unable to get out without a very well-coordinated effort. How can they get the vaccine? Are there any agencies doing in-home vaccination? So,
That's a great question. Dr. Stowe, what do you think?
Yeah, that is a wonderful question. Early in the vaccination process, we had community-based organizations who were kind of thinking in this direction. And there appears to be a unified effort on the Missouri side for the area agencies on aging to collaborate with the state-designated regional implementation teams and collaborate with EMS to get vaccines into the homes of the homebound. So right now, even though that isn't a formalized process, we are checking with each caller who we serve and all of our enrolled clients to see if they're homebound, and then we compare them with an opportunity as it becomes available for in-home vaccinations. And that is a subset in the population that will have to be served. They'll have to be served differently, and I know there is a lot of effort looking at those folks and helping them out. There are parallel efforts in Kansas City, Missouri. I know on the Johnson County side, there are efforts to have a coordinated focused response for the homebound. So I expect more information and more details coming out soon about that.
all right. Mary wants to know, what are the lessons learned for handling the early days of a pandemic that we need to build into our public health systems?
Oh, man, that is a great question.
Complex question.
Yeah.
Complex.
Lessons learned from the early days of the pandemic.
Yeah.
Hawkeye, what do you think?
I think everything starts from the top. And I think you need a good coordinated effort at the top. And obviously we had Dr. Fauci. We need a unified message. And then if you go down and the trickle down, if you will, to these state infrastructures. And we know that the public health infrastructures in really all of the states are not good. So I think it starts from there, trying to get a good unified message out. And then, once it goes down to the individual states, because we know that the individual infection dynamics in any one community is different. So then applying, the top messages, the best messages from the top, and then bringing it down to the states, the infrastructure's there, and not only from the states, but then into every community in the state. I think we really have to work on our infrastructure for public health. We saw what can happen when we are able to put money and resources behind something. We have a vaccine, less than 12 months from
That's crazy, isn't
from the start of the pandemic. So the start of the pandemic here in the United States. So we see what can happen when you have resources and money. We need to start to build up our infrastructure for public health, but for other things as well, because we know how important schools have been shown to be, and we understand that because of some of those reasons, how the school districts are, or the buildings, or whatever that may be, they've had a difficult time of getting back to in-person. Everybody wants to go back to in-person. So I think it's just, we've really learned about the infrastructure, what has been going on, and some of these things that may not have had the resources that have been needed for the past several decades. But I think it's a good starting off point, and I think moving forward, we will see changes.
Yeah, I think the lesson learned is a lesson we've learned so many times in life. It's not about how much glitter and how much gain you have. It's really about how much game you have, meaning your ability to compete against the virus. The virus doesn't care what color you are, or how much money you make, or where you live. The virus doesn't care whether or not you think you can win your way by lying or not telling the truth. The virus is the virus. And what we should have learned from this pandemic is that if we lead each other with compassion and grace, as opposed to glitter and fame, that we can control the spread of the greatest plague that the world has seen in over a century, over 100 years. Our lesson should be if we take care of each other, we can all win. as opposed to having individual people try to win at the expense of each other. That's the lesson. And the more we care about each other, the better we do. The more we care about ourselves, the more failure we get. This is not hard. It's everything you learned in kindergarten. Truth is that faith, hope, and science woven together are an unbeatable combination. If you're not willing to have a conversation that's based in honest truth, then really you don't believe in faith and hope. And you try to destroy science. And that leads to over 500,000 people dying needlessly. That's the lesson, I think. Mm-hmm. And to your point about public health, that is the lesson, right? Because that's taking care of each other.
Two-part question involving the variants. First, when getting a COVID test, does that include testing for the variants? And then, can you talk about this new variant? I've heard that there could be a spike in the cases in the next couple of weeks.
What do you think, Hawk?
Yeah, I mean, there is no specific testing for the variants. We know that the state of Kansas is going to be doing random testing. They're also doing specific testing if a health system or provider has a specific question about a certain patient or an isolate that can be sent in. They are doing just regular surveillance, genomic sequencing. But if you get tested, sometimes we can see that in the testing. They have an S dropout. So most of these PCR tests basically have two things that they're looking for. And the way that they found the UK variant in Colorado was that they weren't able to detect one of those targets to the PCR tests. So they are kind of able to show that, but we don't do specific testing for the variants. We know that currently there's only 2,000, 2,500 cases of the known variants in the United States. Obviously, that number is probably more because we probably haven't diagnosed it all. And then as far as, do we think about the surges? Well, I think we are always concerned that there may be increases in the number of cases. We've gotten down to a lower level, but it's still pretty high of new cases every day. But there's always that concern, and especially as we talked about earlier on in the show, it's going to be warmer. People are probably going to want to get out and socialize more. And I think being cognizant of that fact, that people are doing that we could see an increase or a surge in cases. That's why it's all the more important to get the vaccines into arms.
And I would just add that I think they are doing wastewater testing in Missouri as well as in Kansas, and they are seeing the variants emerge in some of the wastewater testing. So we know it's out there. Yep. I would point out that the J&J vaccine looked very effective against both the 117 as well as I thought it was effective against the 135 or 134, the South African one. And I think that's really good news for us, right? I think that's a really good thing.
Yeah, I think to your point, they actually did provide an addendum to their original FDA brief when looking at the South African variant, which was about 95% of cases in South Africa. It showed to have 81% effectiveness 28 days after the vaccine for severe and critical illness. So, it looks from that amount of data that it is fairly effective as well. And of course, if you're blocking and protecting against severe and critical disease, you're going to be protecting against death. So,
all right. Cynthia wants to know, do you foresee when we will be able to have the ability to vaccinate our college kids? My student has spent her whole year in a California college virtual. And wants to know when we're going to be able to get back to that. Maybe by this fall?
Yeah, well, maybe even sooner. Let's think about that. I think we're going to see a lot more vaccine hitting the market. Pfizer and Moderna have said they're going to have 300 million doses by June, and J&J 100 million. That gives us 400 to 500 million doses. I mean, that's more than the U.S. population there. We include the ones we already have. So then it's just a question of how long it takes us to get that vaccine distributed, because you can get it manufactured, and volume has been a big challenge to us. But I think that's going to tie Jana into knots, because she's going to have to figure out how to make calls to a whole lot more people. But I think that college kids are going to start having that opportunity in this summer. And I don't know if Dr. Stowe, thoughts about that? When do you think the college kids are going to get that opportunity? And what's MARC doing to help make sure we're ready to do truly mass vaccination. Because right now, we're not really doing mass vaccination. We're doing a lot of vaccine on some days. Mass vaccination comes when we got, suddenly in 1 month, we got 200 million doses to give to the country. That's going to be mass vaccination. What are we doing to be ready for that day?
Well, my heart and my focus is on older adults. And so I want to see all of those disproportionately affected, highly vulnerable older people vaccinated before we move on to other populations. But I think that will be soon. And I think you're going to see a lot more functional ability to get to mass vaccine events coming up in the future. And Mark will be there every step of the way, sitting in the shadows, leading from behind, helping to coordinate efforts as we can and offer any assistance that we can.
Yeah, Mark does a great job with that. Jana, how are we going to be prepared as a health system to do this and trying to reach out and call a lot of folks? Because there are so many people that don't have good, access to the internet, or their smartphones may not be able to communicate with MyChart or whatever. And so, are we ready? Or do you have people ready with ready ears and fingers ready to make those phone calls?
We do. There's been a lot of optimizations to our telephony system within the health system. We've got a chance to learn a lot from last year with the uptake in telehealth appointments and with the drive towards testing. We really got a glance last March into some areas with regards to readiness that we could implement. So while there were a lot of concerns last year, I think, from all of us, including our community, we took it as a learning opportunity. So we did some ramping up of staff, of trainings, of skill sets. And so we are ready to go, for this population that either cannot or in some cases will not choose to integrate technology with their healthcare. We are ready to come to them if they cannot come to us.
Love the sound of that, because I think that is so important to make sure we have equitable distribution of vaccine for everyone. Because again, the virus doesn't really care who you think you are. The virus just cares that it can infect you. And we have to take the approach to making sure we vaccinate everyone, because that's how we protect each other.
How about one more?
Please,
we do have a
last
J&J question.
All right.
The single dose, this is from Cynthia. She says the single dose J&J vaccine is less effective than one dose of Pfizer or Moderna, but experts say we still need to give 2 doses of those instead of 1 dose to more people. Can you explain why?
Yeah, I'm going to challenge the stem of that question. I'm not sure, Hawkeye, that we know that 1 dose of J&J is less effective than Pfizer and Moderna. In fact, I would say they look pretty similar from the small amount of 1-dose data we have. Pfizer's doing a 1-dose study they're going to publish or put out this summer, but I don't think we'd have a lot of 1-dose data about Pfizer and Moderna.
Yeah, I think we have to understand, and this happens with all kinds of research articles that we've seen happening throughout the pandemic, where false conclusions are made due to some data points in a study, but you have to understand, what is that study doing? So we have to understand that the Pfizer and Moderna studies were made for 2 doses. They weren't made to draw conclusions about 1 dose, but the study design and the study aim of Johnson & Johnson was for 1 dose, and so that's why we have that information. That's why we have that data. So, but as far as efficacy, we have to understand whatever vaccine you can get, because they are all extremely effective at stopping severe and critical disease and death. So
That's the best news. And I think, it is a great question. So when I say I want to challenge the stem of the question, I wasn't trying to be aggressive. I'm just trying to say that I'm not sure we know enough yet. What I've read is that this Pfizer or the Moderna dose is said to be 60 to 80% effective after a single dose. And so, J&J comes out at 68 to 72%. So it's really exactly the same. And I think I'm still willing to bet, and it'll be interesting to see what Dr. Alt thinks tomorrow, that 2 doses of J&J, which is now being studied, in which they think they're going to have the data out in July, are probably going to look about the same as Pfizer and Moderna. And Pfizer and Moderna single-dose studies, which are also ongoing, are going to probably say, yeah, we're going to land at about the same place as J&J. So at the end of the day, I think there are a lot more similarities here than there are differences. Yeah. The best news is that most important outcome variable, hospitalizations and death, look remarkably the same between all 3 vaccines. And to J&J's credit, even after 1, so I think that'll be great.
Yeah, and even in the studies, some of the addendum, it even looks like the people who get asymptomatic disease, meaning they get disease but don't have any symptoms, that looks reduced in the J&J, some of the J&J data as well. Hopefully we'll get that real life data just as we do with the Pfizer vaccine in Israel, that they published on.
Hey, coming up tomorrow, Dr. Norman is back on the update to talk about the vaccine rollout across Kansas. We also have Dr. Kevin Alt to join us to talk about his work with the CDC Advisory Committee on immunization practices. We'll be talking a lot about the J&J vaccine tomorrow and how this is all going to fit together. Dr. Alt has to vote before he can talk publicly, though, so hopefully that'll have all been taken care of by now. So we look forward to that. It's going to be a great discussion. Let me turn to our panelists today and our guests. First, Dr. Stowe, final thoughts from you.
Yeah, thank you. I just want to remind everyone that we do have a public phone number to help those with digital barrier access on the Missouri side. We can help people become enrolled in the vaccine registry. We can help them with transportation to and from the appointment. And we can help them with reminders for the second vaccine dose if that's the type of vaccine that they're getting. And on the Kansas side, we would encourage folks to reach out to KU, reach out to their local public health agency or their local area agency on aging for assistance.
Thank you, and thanks for the great work that MARC continues to do to support our community and our region through this terrible pandemic. I want to also turn now to Jana Jackson. Jana, final thoughts from you today.
Just relaying again that we are ready and thankfully able to reach out to all populations in the communities that we serve. Right now, we're focusing on 65 and greater. But again, if you cannot come to us, we will come to you. Please give us a call at 913-588-1227. If you're having any level of difficulty or inability to access our website or are incapable or for some reason not able to leverage MyChart, we are here to help and we'll continue to do so.
For the great work that you and your team have been doing, as we talked about before on this program, it clearly takes a team to get us through the pandemic. We appreciate the participation of you guys and the great work that each of you have done. Hey, as we say goodbye today, Nancy Weaver and her husband David reached out to us about our 1-year anniversary of this update. Nancy wrote, "We're devoted watchers of the morning media update. We wanted to say thank you. My notes now are telling me to ask Bob to put on his mask and come forward for the rest of this story." Bob?
Nancy and David have a little something for the both of you, and I'll let you open that up.
All right, Hawkeye, you gotta insist.
Okay.
That is very kind. Nancy and David, thank you. You don't have to do anything. Our joy is actually being able to come here and mess around with everybody every day and just try and tell the truth about this whole thing.
Don't be too picky now.
We're going to give you lessons on how to dig into a bag, Hawkeye.
All right, here we go.
All right, let's see what this looks like now. Yeah, see, this is why I gave him to do it, because it required some degree of dexterity, and anybody knows me is that is not my strong point. Oh, yeah. There's no place like home bugs. I love that. That's awesome. Because, and it's got a baseball heart on there. Is that the best or what? We love that.
I'll use it for my coffee.
I like that. Thank you very much. Nancy and David, it is us who thank you. The pandemic is a public health threat. It's a threat to all of us. Again, it doesn't care who you are, what state you live in, what county you live in, who you think you are, how much money to make, how big your house is, what color your skin is, how educated you are. The virus doesn't care about any of that, because in the eyes of the virus, we are all equal. And it takes all of us to push back. We hope that you have learned and gotten something out of this morning media update, and then go home and practice and share the pillars of infection control, which we talk about pretty darn often, I think at least once a day. Help get us all safe and make sure we all get vaccinated, because the vaccine is the culmination of faith, hope, and science. Thank you for tuning in on every morning. We never thought we would be approaching a year of these morning briefings. At least I didn't. Did you think that?
No.
I guess maybe we should have. Our promise remains the same, though. We're going to be here each and every day as long as we are needed to answer your questions. Because, pandemics are hard. And if we can work together to share that, and we share it with people who we know have been affected, like Michelle, and families and people all around our area and all around the world, then we will have helped every person just a little bit to get through the pandemic. And that's why we're here. And remember that up until this moment and throughout all the day long and even into every day yet to come. The rules of infection control, they travel with you and they will keep you safe all the day long. Until then, we'll be back tomorrow. There's still no place like home. We'll see you soon.